So today I am here to discuss the GT 185 questions of physiology. So we're going to discuss the GT 185 and we'll discuss the questions of physiology. Question number from 203 to 218. So let's start off with the question number 203, right? So question number 203 says that the arousal is most difficult in which stage of the sleep. So for this question we should know what are the different stages of the sleep and what function they provide us. So let's discuss question number 203, sleep. So one sleep cycle is of 90 minutes. So duration of one sleep cycle is of around 90 minutes. So remember, if they ask in the entrance exam, any entrance exam, that if a person sleeps for example 3 hours or 6 hours. So let's take an example of 6 hours. If a person sleeps for 6 hours, so how many sleep cycles will be there? Remember, there will be 4 sleep cycles in which there are 2 phases of the sleep and different stages, that is NREM sleep and the REM, non-random eye movement, and yes, the rapid eye movement. So NREM and rapid eye movement, right? So each will be of 4. So 4 NREM stages will be there and 4 cycle of REM stage will be there. So they are equally divided into 4 parts in the 6 hours of sleep. Remember, this question is already asked. They will give the number of hours and they will ask how many sleep cycles that person will complete, right? So this is about the NREM, REM. There are different waves in which in the different phases of the sleep. So let's see how the sleep can be divided in another phases, that it is divided into 2, NREM and REM, right? The sleep actually start with the NREM stage 1. It begins with the NREM 1 and it is also divided into light sleep and the deep sleep, right? So for example, light sleep and deep sleep. Light and the deep sleep. But remember, the both have only the NREM stages. So in light sleep we have NREM 1 and 2, NREM stage 1 and 2. Then in the deep sleep we have NREM 3 and 4. Remember, in light sleep it is very easy to arouse a person. So it is easy to arouse. In light sleep it is easy to arouse a person, while in a deep sleep it is difficult to wake up. It is difficult to wake up. There is one more stage is remained, that is the NREM 4 will be followed by the REM stage. Right? It is, in some books it is referred as a stage 5. It is known as a paradoxical sleep. It is known as paradoxical sleep. Now, why it is known as a paradoxical sleep? Remember, it have a alpha and beta waves in the sleep in the EEG, but in the REM also it is very difficult to arouse a person. So write down why it is known as a paradoxical sleep, because the sleep have a alpha and beta waves also. Alpha and beta waves also. in the in which sleep? In the REM sleep, in where? In the EEG, in the EEG. But it is difficult to arouse. It is the sleep, it is difficult to arouse. Difficult to arouse. And if you want to know how this waves are actually coming, for this wave we have a small and simple chart that if we have to learn the EEG waves, we can divide simply into two types. The EEG will be divided into two types. What are those two types? Yes, if the person may be awake or in the sleep. So write down awake and sleep. The person can be awake or sleep. We can perform the EEG on that person, right? In the awake also, we again divide that part into two subheadings. One can be less active mind, or highly active mind. Highly active mind. Remember, in less active mind, you have a alpha wave. You'll get a alpha wave. And in highly active mind, you'll get a beta wave. And what you mean by less active mind? They can frame a question like the eyes are closed or open, the disturbances surrounding in the environment, right? So if the less active mind is there, that means the eyes are actually closed. The visual stimulus is not actually there. So eyes closed. There is no disturbances. And how the mind will be? The mind is actually free and wandering. And one more question can be asked on the wave, that is, what are the frequency of that particular wave? So frequency, write down. Frequency is around 8 to 13 hertz. And where this alpha waves are produced, they are produced by which part of brain or the CNS? It is from the thalamus. The formation of alpha wave is done by the thalamus. So all these questions are already framed. On the alpha wave, we have 3 questions till now in all the past 4-5 years. That is, they frame a question: if the eyes are closed and mind is free wandering, what wave you'll get in the EEG? Then you should go for the alpha wave. Then on the frequency and in which part of CNS it is produced. So all of these questions are asked on the alpha wave. Similarly, if we have to have a look on the beta wave, what we can see in the beta wave? Yes, the eyes. About the eyes are usually open. Obviously, a highly active mind is there, and a highly active mind means the visual stimulus is must over there. So eyes are open. We have a strong sensory stimuli. In the alpha wave, we have no disturbances, right? But in the beta wave, we have, yes, strong sensory stimuli. So in the beta wave, strong sensory stimuli. And that's why the brain is highly active. And in the alpha wave, mind was free wandering. What about the beta wave? It is highly active. So active thinking is there. Or else you can write the concentrating mind. What is the best example of alpha wave? It is the meditation. And what can be the example of a beta wave where you have a concentrating mind and you have a strong sensory stimulus and you need to do a active thinking? That will be mathematical or logical problem solving. Where you require the active thinking and concentrating mind. What is the frequency of a beta wave? Write down the frequency is 14 to 30 hertz. 14 to 30 hertz. What about the production? It is produced. Remember, highly active mind is there, and the wakefulness or the alertness is majoritarily the function of which system? The RAS system. So production is by the RAS, reticular activating system. The reticular activating system. It is a function of RAS, right? So that is all about the beta wave. That is all about the beta and alpha wave. Let's come towards the sleep, division of sleep. Again, as we divided or subdivided the awake stage, we can divide the sleep also. One can be the light sleep and another is the deep sleep. Light and the deep sleep. Light and the deep sleep, right? In the light sleep, which wave you will see? You will see a theta wave. Theta wave. And what about the deep sleep? Deep sleep, you have a D, so delta wave. How to remember? Many questions asked on this delta wave, particularly in deep sleep. What wave you will get? What are the frequency of wave? Where it is produced? So, how to remember? In the deep sleep, you have a D. D for delta wave. D for deep sleep. D for delta wave and D for deep sleep. As we already discussed, in the light sleep, it is very easy to arouse. So, it is easy to arouse. And what about the deep sleep? Yes, it is difficult to wake up. It is very difficult to wake up. What about their frequencies? Frequency of theta wave is 4 to 7 hertz. 4 to 7 hertz. And what about the deep sleep? Remember, the wave frequency is depending upon how active your mind is. It is directly proportional to the activity of the mind or how the neurons are stimulating, how they at what rate they are firing, right? So if you are actively thinking, there will be more. The frequency of production will be more, right? If you are in the deep sleep, there will be very, very less. That is, the frequency is 0 to 3, or you can say less than 3 hertz. Less than 3 hertz. What about their production? Remember, the light sleep, that is the theta wave, it is produced by which part? It is produced by hippocampus. It is produced by hippocampus. And what about the delta wave? Delta wave, it is produced by which part? It is produced by the hypothalamus. Hypothalamus. So this is a short and simple chart which you can remember for the EEG, part, right? So let's revise quickly. That is, in less active mind, in the awake state, you will get a alpha wave, right? You will get a alpha wave. And what is the frequency? 8 to 13 hertz, 8 to 13 hertz, and it is produced in the thalamus. It is produced in the thalamus, right? And what about the beta wave? Beta wave is produced into highly active mind, and mathematical problem solving is one of the example. Frequency is higher, that is 14 to 30 hertz, 14 to 30 hertz, and it is produced in the RAS system. Alertness and wakefulness, that comes from the RAS system. So obviously the beta wave produced by the VRAS system. What about the other system? That is, in the light sleep, the theta wave is produced and the frequency is 4 to 7 hertz. 4 to 7 hertz and produced by the hippocampus. And D for deep sleep. In the deep sleep, we have which EEG wave? Delta wave. And what is the frequency of delta wave? It is 0 to 3 hertz and produced in the hypothalamus, produced by the hypothalamus. If you have to revise this, at least you should remember the deep sleep. Many questions came on the deep sleep and the beta waves as well as the alpha. But yes, the two main parts of this, majority questions comes on the deep sleep and the beta wave. Remember, if they gave gamma waves, so the gamma waves having the frequency of more than 30 hertz, usually it is seen in the seizures or epilepsy patients. So no question asked till date, but for the sake that it can come in the future, you should know that the gamma waves are also there in the EEG, but they are usually not normally seen. They are seen in the patients of seizures, epilepsy, etc. So we do have a EEG wave diagram. So let's have a quick look on this. If the person is awake with the mental activity, you're gonna see the beta wave. And how the hertz are calculated? Remember, how many waves are actually forming in 1 second. Remember, in 1 second of duration, how many waves are actually forming, that much hertz we're gonna write. So over here they gave the 1 second duration, and as per how many waves are forming, we get to know the activity of the brain. So in mentally active brain, beta waves are formed, which having a frequency of 14 to 30 hertz. What about awake but resting? Remember, in alpha wave we should remember the eye should be closed. So over here in 1 second we have 18 to 30 hertz, right? 8 to 13 waves are seen in the 1 second, so 8 to 13, that is nothing but the alpha wave. What about the sleep? In the light sleep we have a theta wave, and in the deep sleep we have delta wave. Over here they wrote 3.5 hertz, but usually we take it as 3. In this you can see for 1 second you have only two waves. That means it is a deep sleep. It is a phase of deep sleep. Coming back to our question, that is arousal is most difficult in. So we wrote that arousal is difficult into REM also, and NREM 3 and 4 stage also. So out of these two, we'll choose the NREM stage. Why? Because the paradoxical sleep phenomena is there in the REM. It is there in the REM sleep. So out of these two, if we have to choose, we will go for the NREM 3 and 4. So option C will be our answer, NREM 3 and 4. NREM 3 and 4 will be our answer. So answer of question number 203 is C, right? Moving to the next question, micturition center is present in. So there are two centers for micturition. What are those two centers? One is present in the brainstem. So let's discuss the next question. About the micturition. So there are two centers for micturition. Control of micturition. You can write the higher centers there are two higher centers for control of micturition. Higher centers for control of micturition. Which two centers are there? One is in brainstem and one is in cortex. One is in cortex. In the brainstem, where it is actually present, if you have to specify the area, it is present in pons. It is present in pons, which is usually known as PMC, Pontine Micturition Center. Pontine Micturition Center. Which is present in brainstem, right? What about the cortex? Cortex, in which area of the cortex? It is present in medial frontal lobe. Medial frontal lobe, and that is the answer of our question number 204, right? In the cortex we have medial frontal lobe. Now if we talked about that, let's see why the two different centers are required. The PMC, the Pontine Micturition Center, it is for involuntary control. Involuntary control of micturition. Involuntary control of micturition. And how does it act? It acts via the parasympathetic sacral roots. It acts via parasympathetic sacral roots. And what is the root value of that? Remember, the root value is asked in many exams, so you should remember it is S2, S3 and S4. Sacral root and root value is S2 to S4, right? What about the frontal one? It is basically, mainly it is for voluntary control. It is for the voluntary control. Voluntary control. What it actually does? It relaxes the external urethral sphincter. So write down, the function is it relaxes the external urethral sphincter. It relaxes the external urethral sphincter. So that is about the higher centers and their control on the micturition. We do have a diagram for this also. Let's have a look on that too. So this is how the micturition is actually controlled. There is a association cerebral cortex, right, in which the cognitive interpretation of situation is occur. And over here, what we are talking about, which situation? The micturition. So from the bladder, the afferents will come, which are basically the mechanoreceptor, right? Examples they gave, the awareness, fullness and urgency will be counted over there. And from the limbic system also, limbic system is for emotion, the emotional control is also there. Depending on the emotional behavior, the signals are also coming from the limbic system. Where they actually combinedly goes to, it will goes to the which area of the forebrain? That is the medial frontal cortex. Medial frontal cortex. It will decide and give the further signals to the midbrain. Then from the midbrains towards the pons, and either one of these will be stimulated. If the signal is for the micturition, then this pathway will activate it, and that will excite the detrusor muscle and they will inhibit the sphincters. That means the sphincter will open up and the micturition will take place. If the negative signal will come towards the pons, what will happen? The continence center will be activated and that will excite the striator sphincter. The sphincteric control will be there. So that's how the micturition centers will work. Over here they are shown the PMC center, and what we were talking about, the involuntary control S2 S4. The root value is S2 S4. So this is about the micturition and micturition reflex. So answer over here is medial frontal cortex. Medial frontal cortex. The answer of question number 204 is option D. Let's move on to the next question, that is unit of stretch reflex is. Remember they asked about the unit. So the answer should be reflex arc. So answer over here is the reflex arc. Let's discuss few points about the reflex arc. How does it work and what other questions can come from this reflex arc. So question number 205. The unit of the reflex arc, the unit of reflex or the stretch reflex, rather you can write the unit of stretch reflex is the reflex arc. The reflex arc, right? Let's discuss few points about the stretch reflex. Stretch reflex. This reflex is also known as DTR. What is that? Deep tension reflex. It is also known as DTR, deep tendon reflex. Deep tendon reflex or loading reflex. Loading reflex or a myostatic reflex. Myostatic reflex. This is the monosynaptic and the segmental reflex. Remember, many questions ask on this also. So what is that point? Yes, it is monosynaptic. One synapse, only one synapse is there in this reflex. Monosynaptic and segmental reflex. This stretch reflex is monosynaptic and segmental reflex. If we have to give example, there are many examples of deep tendon reflexes. We have to perform those in the first years of physiology, right? So example is biceps, triceps, knee jerks and all. So biceps, what is the root value? It is C5 to C8. C5 to C8. Another example in the lower limb, knee jerk, and what is the root value of that? L1, L2, right? That is a root value, and those are the examples for the stretch reflex. Stretch reflex. How we used to perform the stretch reflex? Whenever we want to elicit the stretch reflex, what we do is we strike the patellar hammer on that particular tendon of that muscle. So what is the stretch reflex? Stretch reflex is whenever you give a signal or you stretch a muscle that will contract. The simple one line sentence for the stretch reflex: whenever adequate stretch is there, you stretch a muscle. If you stretch a muscle, that will contract. That will contract. That is a simple equation for the stretch reflex. And how the mechanism is going on behind it? How we stretch a muscle? Via the patellar hammer. Suppose we strike a patellar hammer and we stretch a muscle. What happens? Whenever we stretch a muscle, there will be increase in length of the muscle. Increase in the length of the muscle. And in response, what we are getting? decrease the length back to normal. And that is the stretch reflex. Once we increase the length to maintain the homeostasis, what will happen in the response? The muscle will contract and it will maintain its length back to normal. How it is activated? Whenever we stretch a muscle, that will activate the length receptors. Which are the length receptors? Length receptors. And which are those length receptors? They are nothing but the muscle spindle. So the length receptors, they are getting activated or stimulated, and which are those? The muscle spindle. They are stimulated once the length of the muscle is increased, right? And in turns, what will happen? This muscle spindles, once they are activated through the nerves, which nerve? Yes, the 1A and 2 sensory nerves. What they cause? They will cause the activation or stimulation of alpha motor neurons. Once this alpha motor neuron is activated, we know the major function of the alpha motor neuron is to do the contraction of the muscle. Once they are activated, the alpha motor neurons, they are activated, they will cause the contraction, and through which nerve? Via the motor nerve. Via the related motor nerve, they will cause the contraction of that particular muscle. So that is the whole phenomena of stretch reflex. How the stretch reflex is activated? Whenever you stretch a muscle, there will be increase in the length of the muscle. Whenever you stretch a muscle, increased length of the muscle will be there. That will stimulate the length receptors, which are nothing but the muscle spindle. The muscle spindle, once they are activated, in turns they will activate or stimulate the alpha motor neuron through which nerves? Through sensory nerves 1A and 2, right? And once this alpha motor neuron is activated through the motor nerve, that will causes the contraction of that particular muscle, and that's how the length of the muscle is regulated. So basically, if we have to write what is the function of stretch reflex, in one line, it correct and regulate. One of the property, that is it correct and regulate the muscle length. Right? So that is all about the stretch reflex. What you have to remember is the stretch reflex is related to the length, that is related to the muscle length. And remember, many questions asked on these sensory nerves, and the muscle spindle are the length receptor. At least these 4 points should be remembered. So that's how the stretch reflex is activated, and the reflex arc will work. So this is a short and simple reflex arc. Whenever you give a sensation, the sensory nerve will carry forward the signals. The afferent roots are going from here. The interneuron is there, which release the neurotransmitter and which activate the motor nerve, and hence that's how it will go towards the muscle. And that is nothing but the reflex arc. A simple reflex, that is the unit of stretch reflex, the reflex arc. Moving on to the next question. Not true about the vasopressin. Not true about the vasopressin. Before knowing what is not true about the vasopressin, let's see what are the facts that are related to the vasopressin, So, let's talk about the, yes, which question? Question number 206. 206. The vasopressin. The vasopressin. What this vasopressin is also known as? It is also known as ADH. ADH, which is the antidiuretic hormone produced by the hypothalamus but stored in the posterior pituitary. Remember, it is produced by the hypothalamus, not by the neurohypophysis, that is the posterior pituitary. It is just stored in the posterior pituitary. And which part of the hypothalamus it is? Produced by hypothalamus. Remember, the hypothalamus is nothing but the bunch of nucleus. It is a bunch of nucleus, and which nucleus helps in the production of the ADH? That is nothing but it is produced from supraoptic nucleus. It is produced from the supraoptic nucleus of the hypothalamus. Supraoptic nucleus of the hypothalamus, right? So, if it is, once it is produced, what will happen? It will go and act on the, yes, the nephron. But for that we require a stimulus. For having any response, we require a stimulus. So, what is the stimulus for ADH? There are three major stimulus for ADH release. That is, one, the first and foremost important thing is the high osmolarity. High osmolarity. Remember, it is antidiuretic hormone. Antidiuretic, that means more and more water reabsorption will occur once this ADH are released, right? So, response is always inversely proportional to the stimulus. Whatever stimulus is there, the contrast response will occur, right? So, once the high osmolarity is there, the ADH will be released, there will be inhibition for the diuresis of water, right? And what will happen? The osmolarity will be recovered back to normal with the help of the ADH, right? So, that is one of the stimulus. What is the other stimulus for it? We are doing the water reabsorption. So, once if the hypovolemia is there is a decrease volume of the plasma or the blood. What will happen? The ADH will be released and more water will be reabsorbed. And the third most important stimulus is the angiotensin II. Angiotensin II through the RAS system, renin angiotensin system, right? So, these are the three main stimulus for the ADH release. Then how it act? ADH act through the two receptor. Remember, ADH have two receptors. ADH has two receptor. What are those two receptor? One is the V1, and another is the V2. One is the V1 and another is the V2. This V1 will act via IP3 DAG. Remember, by the endo system, there are three types of secondary messenger. One is cyclic GMP, the another one is the cyclic AMP, and the third one is the IP3 DAG. This V1 receptor will be activated through which GPCR system? The IP3 DAG. IP3 DAG. What it will cause? It will, once this IP3 DAG will be activated, that will in turns will increase the calcium levels. Once the calcium is increased, what will happen? contraction will take place. Contraction will take place. Contraction of what thing? The afferent and efferent arteriole. Afferent and efferent arteriole. And once the contraction is through this V1 receptor, what it is doing actually, it is regulating through it, it will regulate the GFR. It will regulate the GFR. So that is the function of the V1 receptor of the ADH, V1 receptor of the ADH. Let's see what this V2 receptor will do. What this V2 receptor will do. Where they are present? They are present on the P cells. They are particularly present on the principal cells, P cells or the P cells. Where these P cells are present? They are present on CD, the collecting duct. P cells in the CD, that is in the collecting duct. Once these V2 receptors through the ADH will activated, they act via this on this P cell. How they act? They act via which secondary messenger? They act via cyclic AMP. They act via cyclic AMP. Once this cyclic AMP is increased, what will happen? They will increase the protein, which is the increase in aquaporin 2. This receptor is nothing but the one of the type of protein which is increased when there is an increase in cyclic AMP in the P cell via the release of ADH on the V2 receptors, right? Once this aquaporin 2, the name itself suggests that it is aqua, right? And they have a pores, and through which pores? Through this pores, the pores, that means through these gates, what will happen? More and more water will be reabsorbed. So that's why it is known as the aquaporin, right? So what will happen through these pores? More and more water reabsorption will be there. More and more water reabsorption is there. What will happen to the urine? That's how the hypertonic concentrated urine is produced. Hypertonic concentrated urine is actually produced via more and more water reabsorption, right? So this is all about the ADH. This is all about the ADH from its production towards its action, from its production to the action. So let's see, come back to the question, what is not true about the vasopressin? So it reduces the rate of urine formation. Yes, because the concentrated urine is formed. Major action is on kidney through the V2 receptor. Yes, just now we saw via increasing the cyclic AMP that will absorb more and more water. So yes, via increasing the which receptors? Aquaporin 2, right? Predominantly synthesis by paraventricular nucleus. Remember, it is produced by the supraoptic nucleus, not by the paraventricular nucleus. So answer of this question, why? Because they ask not true about the vasopressin. So answer should be C. Answer should be C. And major stimulus for secretion is osmolarity of the plasma. Yes, the high osmolarity of the plasma is the major stimulus for the ADH or the vasopressin. So that is all about the question number 206. Let's move on to the question number 207. Okay, they gave a diagram. You can see this is nothing but the, if you peel or cut the onion, it is looking like that, right? It is the onion shaped receptor. So which is that? It is nothing but the Pacinian corpuscle. Pacinian corpuscle. So let's discuss the question number 207. Let's discuss the question number 207. 207. The receptor which is shown in the diagram, it is the Pacinian corpuscles. It is nothing but the Pacinian corpuscles. Pacinian corpuscles. What they do? What are their properties? Remember, they are rapidly adapting, but they have a high threshold. So write down, they are rapidly adapting, but the threshold is high. So rapidly adapting, high threshold receptors. They are high threshold receptors. Rapidly adapting high threshold receptors, right? So why and how we can justify the high threshold receptors with the pressure? So they are high threshold receptor, that's why it sense what thing? That's why it sense the pressure. It sense the pressure. And where they are present? They are present in the deep dermis. They are present in the deep dermis. How we can justify this? If you give a low threshold stimulus, what will happen? The touch receptors will be activated, which are in the epidermis, right? It is logical that if you give a fine stimulus or very low threshold stimulus, what will happen? Only the touch receptors will be activated, and if you give high threshold stimulus like this, the pressure receptors will be activated. So that's why the high threshold receptors, which are located in the deep dermis, they are nothing but the Pacinian corpuscles. They are nothing but the Pacinian corpuscle. And what is their shape? They are onion shaped. They are nothing but the onion shaped. In the dermis that we talked, that it sense the pressure. It sense the pressure. They are also present in the joints. They are also present in the joints. In joints. So they are also present in joints. And what they sense in the joint is, they sense the vibration sensation. They sense the vibration. In the joints, if they specifically ask, in the dermis, they sense the pressure sensation, and in joints, which sensation they will sense? They will sense the vibration in the joints. Vibration in the joints. If we have to draw, let's draw a simple diagram of the Pacinian corpuscle, the onion shape. So it's very easy to draw. So like this, they have their body, and suppose this is the myelin sheet over them. Suppose this is the myelin sheet over them, through which the saltatory conduction will take place. Saltatory conduction will take place, and somewhere in the middle they have DRG. What is DRG? Yes, the dorsal root ganglion, right? So this is the DRG. This is the DRG, which is the cell body of the DRG, right? Okay, and this is nothing but the Pacinian corpuscle. This is the initial segment, and they asked in the diagram they gave, and they asked about where the epigenesis will occur. Remember, the epigenesis, that is action potential genesis, is always takes place at the axon hillock. Why? Because of the low threshold over there. The axon hillock have a low threshold, so it is the axon hillock. If the axon hillock is not in the option, you will go for the initial segment. This is the whole total initial segment, where what happens? The action potential genesis or production will be there. Action potential genesis will be there. right? And remember, it is carrying forward the sensation. So the sensations are coming from which horn of the spinal cord? Yes, from the dorsal, it enters in the spinal cord through the dorsal horn. So through the dorsal horn or dorsal root, it will of spinal cord, it will enter into the spinal cord. Because it is a sensory, and by the which rule? Bell-Megendry law, we know that all the sensory fibers, they are coming via the dorsal horn, right? So that is all about the Pacinian corpuscle. That is all about the Pacinian corpuscle. So let's see in the exam, in the question what they ask. They ask cutaneous receptor. Remember, cutaneous, they didn't ask over here about the joint. So cutaneous receptor type is shown in the image, right? So this is the Pacinian, and yes, the pressure sensation will be carried by the Pacinian corpuscle. How to remember? How to remember that the Pacinian will carry the pressure, So P for the Pacinian, P for the pressure, So that's how you can remember easily. But remember, in the joint, it will not carry the pressure, it will carry the vibration, So that is all about the question number 207. Let's move on to the next question, 208. Which of the following statement is true with regards to Golgi tendon organ? We saw the stretch reflex over here. Basically they are, yes, receptor for the tension. So let's discuss what thing? The tension. That, remember, we already discussed about the muscle length. So muscle have two properties. We are discussing about the question number 208. Muscle have two properties. In short, what are the two properties for the muscle? One is the length, one is the tension. One is the length and another one is the tension. So we have two different properties, so we require two different receptors to sense them and regulate them. So because muscle have two different properties, what will happen? We do have, so we require two different receptors to sense and regulate these two properties. Length. What about the length? Which receptor will sense and regulate the length? We just now saw that it is nothing but the muscle spindle. Right? And what about the tension? T for tension and T for tendon. So Golgi tendon organ. How to remember? Again, T for tension, T for tendon. So the tension is sensed and regulated via the Golgi tendon organ. Right? So we have two different receptors for two different properties of the muscle. So if we have to discuss the for the muscle spindle activation, we saw the stretch reflex. Let's see something known as inverse stretch reflex. What is the inverse stretch reflex? This is also known as the stretch reflex have many names. So inverse stretch reflex is also known as, it is also have another name which is known as the lengthening reaction. And what is the stimulus for this inverse stretch reflex or the lengthening reaction? It is also containing the stretch. So the stimulus should be stretch. But if you give the stretch, what will happen? Which reflex will be activated? The stretch reflex will be activated. So what is the difference between the stretch reflex and inverse stretch reflex? Yes, whenever you give strong, or you can write excessive stretch. Strong or excessive stretch, what will happen? The Golgi tendon organ, they will be stimulated, which are nothing but the which receptor? The tension receptor. The tension receptors will be stimulated, which are known as the Golgi tendon organ. The Golgi tendon organ. Remember, by the example of this wire, we can elicit this stretch and inverse stretch reflex. What happen in the muscle, whenever you give the stretch and up till a limit, right, what will happen? The length will increase. Suppose this is the muscle fiber, one of the, suppose for example, take that this is the muscle fiber, right, and if it is a muscle fiber and we give a stretch, what happens in the initial stage? See, the length is increasing, right. If I give a strong stretch, now what happening? The length will not increase, the tension in turns will increase. The tension will in turns increase, and if the tension continues to increase and in this stage muscle try to contract, we are giving the tension, and the muscle, if it tries to oppose it, what will happen? It will land up into, the muscle fiber land up into the rupture of that fiber. So when there is a strong or excessive stretch, what actually happens? The tension receptors, they will be activated, and through which nerves? Through 1B afferent nerves, afferent sensory nerves, that will actually inhibit the alpha motor neuron. Remember, they will inhibit the alpha motor neuron. They will inhibit the alpha motor neuron. Hence, this alpha motor neuron, again through the motor nerve, once they are inhibited, the signals cannot be passed through the motor nerve. So this motor nerve is also not able to pass the stimulus, and the muscle relaxation will be there. Muscle relaxation will be there. So this is the inverse stretch reflex. This is the inverse stretch reflex. What is the stimulus? The strong or excessive stretch. Remember, I just now showed you that initially when the stretch is applied, what will happen? The length will be increased and the muscle will try to contract and try to regulate the length. But whenever the excessive stretch is there, what is happening over here is there is an increase in the tension. There is an increase in the tension, and via activating the GTO, that is the Golgi tendon organ, what will be the response in turns? Decrease in tension back to normal. Right, and what function it provides us? Yes, important one, that it prevent the rupture of the muscle. It prevents the rupture of the muscle, and also it also regulate the tension inside the muscle, right. So this is about the inverse stretch reflex, right. What they asked about the Golgi tendon organ. So it senses the muscle tension, and not only sense but it will regulate the tension inside the muscle. So answer should be D, muscle tension. They ask about the dynamic length and in reciprocal innovation. Let's discuss. let's discuss about the option number C, that alpha motor neuron, that is not A motor neuron, this is alpha motor neuron stimulation. Remember, in the Golgi tendon organ, once they are stimulated, what will happen? There will be inhibition of alpha motor neuron, not the stimulation. So C cannot be the answer, right? Let's talk about something about the, yes, dynamic and static length of the muscle, and yes, the reciprocal innovation, which is the Sherrington law. So we have two types of muscle fiber, inside the capsule intrafusal muscle fiber, and outside the capsule extrafusal muscle fiber, right? So our intrafusal muscle fiber, they have two types of fiber, intrafusal muscle fiber. Remember, this intrafusal muscle fiber, again they are subdivided into two types of muscle fiber, that is the nuclear bag fibers and the nuclear chain fibers. So two types, nuclear bag fibers and your nuclear chain fibers. How they look like? It's like a bag. So and then on a chain. Why? Because they look like a chain. So these are the nuclei, right? They're present in the bag shape, and these are the nuclear chain fibers. Their arrangement is in the chain types, right? Chain types. So this is a bag fiber and this is the chain fiber. What they do is, yes, they mainly sense the velocity of length change. The nuclear bag fibers, remember, they can sense the velocity because they are present in the bag shape, right? So what they sense? They sense mainly the velocity of length. So it will sense the velocity of length change. It will sense the velocity of length change, right? And it will sense the velocity change, right? Velocity change. That's why they are known as the dynamic fiber. That's why they are known as the dynamic fibers, right? What about the chain fibers? Remember, they basically sense the static length, before and after. They can sense the before, they will sense the length before and after the length change. So they are known as, yes, they sense the static length whenever you are resting or static. You can write over here the resting length or the static length. So they are known as static fibers. So remember, it is not done by the GTO, the dynamic fibers. They are not the GTO, they are the nuclear bag fibers. They are the nuclear bag fibers, right? And what about the reciprocal innovation? So write down. Let's see the funda of reciprocal innovation. It is given by a great scientist, which is, yes, which one was that? The Sherrington. So it is known as the Sherrington's law. It is known as the Sherrington's law or reciprocal innovation, and which is done by the inhibitory neurons, by inhibitory neuron. What it suggests or what it states, remember whenever we are doing the contraction, for example the biceps contraction, right? So if I have to contract my bicep, my tricep will also have to relax, right? Otherwise if both will contract at the same time, I'll not able to move my limb, or I'll not able to contract any of this muscle. So whenever I wanted to contract or I wanted to flex my arm, the contraction signals are sent to the biceps, as well as the relaxation or lengthening signals are sent to the triceps. So same law is the Sherrington law. What is that? Whenever a group of muscle will get the or receive an impulse, write down, whenever, if I have to say that, this law state that whenever a group of muscle, any group of muscle, whenever a group of muscle will receive an impulse for what? To contract, remember, and same amount of impulses, or you can say the equivalent inhibitory impulses. So once they are received the impulse to contract, and an equivalent inhibitory impulse is sent to its antagonist group. So its antagonist, that means the opposite group of muscle, right? Antagonist muscle, and that's how the contraction will take place of that particular muscle. Contraction of that muscle, and in the opposite group of muscle the lengthening will be there. So that's how the lengthening and the contraction will go hand in hand, and it is done by, as we already discussed, it is done by the inhibitory interneuron rather than inhibitory interneuron, not neuron. It is done by the inhibitory interneuron rather than neuron. You can write inhibitory interneuron, and that is nothing but the Sherrington law or reciprocal innovation. So if I have to extend my arm, my triceps should be contracting and my biceps should be relaxing at that time. So lengthening in the biceps, whenever I wanted to extend my arm, what will happen? Whenever I want to extend, the triceps will contract, and the antagonist group of muscle, that is the biceps, they will lengthen up. So that is nothing but the Sherrington law. So that is all about the, yes, all the concept regarding this GTO and all the options given in the question number 208. Let's move on to question number 209. Which of the following is not the function of estrogen? Okay, so we have to talk about the estrogen. You have a diagram for it. So regarding the ovulation and menstrual phase, you guys learn a lot about this in the gynecology, so we will stick to some concept and we'll move on to the next question. So you can see the various hormones which are released during the ovulation, right? We suppose that the ideal ovulation or menstruation phase is of 28 days, and the ovulation will occur at the, yes, which day? At the 14th day, right? So you can see the blue one is the estrogen. The blue one is the estrogen, and it is secreted where? Yes, it is secreted in the first phase of menstrual cycle, and it will go down in the second phase, and the main hormone in the second phase is the progesterone, and LH surge is there in the yellow color. LH surge is there at around 14 days, that is at around the ovulation phase. So remember, the first phase is a follicular phase. It is a follicular phase. Why the follicular phase? Because FSH is released and the follicular growth and development is occurring at this phase. So this is known as the follicular phase. Then during the ovulation, what will happen? The ovum will come out of the corpus luteum, and after this, once this ovulation occur, the carpus luteum start to secrete the progesterone. That's why in the second phase the progesterone will be more, and that's why it is secreted by the carpus luteum. That's why it is known as the luteal phase. That's why it is known as the luteal phase, right? So basically they ask in which phase. If they ask which phase the estrogen is more, in the first phase. In the first phase the estrogen will be more. So if we have to discuss the points regarding the estrogen, there are not much more points. Why? Because all the concepts are better discussed in the gynecology. So physiology related questions are, yes, the estrogen, they are released in the first half. Right now the estrogen released in first half of what? Of menstrual cycle. First half of the menstrual cycle, which is causing the proliferation or the proliferation of endometrium. So it is also known as, the follicular phase. Why? Because the growth and development of the follicles are going on. It is causing the, similarly at the same stage, it is causing the proliferation in the endometrium. So it is also known as proliferative phase. It is also known as the proliferative phase, right? But it is not the secretory phase. The second half, what happens in the second half? In the second half, the progesterone, which hormone? The progesterone will increase. The progesterone will increase more than the estrogen, So, and it is secreted by carpus luteum. So it is known as the luteal phase, as well as it is also known as the secretory phase. It is known as the secretory phase, and which is always and always due to the progesterone. Always and always due to the progesterone. Remember, the proliferation is due to the estrogen. So what is the significance? What is the clinical significance of this phase due to the estrogen? Remember, it is never given alone in the especially in the adult females. Why? Young or the adult females. Why? Because it can cause the endometrial CA, endometrial carcinoma. So it is always and always, whenever if you have to give it as a treatment, you combine it with the progesterone. You combine it with the progesterone. So question number 209, which is not a function of the estrogen. Obviously, synthetic function of the endometrium, yes. The cause, secondary sexual characters in the female characteristics, yes, it is due to the estrogen. Breast enlargement during the puberty, yes. Why breast enlargement? Because growth of the yes, the breast or mammalian tissues are due to the estrogen. So yes, that is also a function of the estrogen. But what is not the function? The secretory function of the endometrium, when it causes in the second half, which is done by the progesterone. So answer of question number 209 is the secretory function. Secretory function. Let's move on to the question number 210, that is, which of the following occur when he changes from the supine to the standing position. Okay. So let's see what are the different changes that occur due to the postural change. Due to the postural change. Remember, whenever a person changes its position, in our question, what is the change? From the standing towards the supine, from standing to supine, right? And they ask what changes occur over there. Remember, whatever postural change is there, always and always the first change will be the venous return. The first change is always and always venous return. All other changes are nothing but the response to that change in the venous return, but the only change which occur at first, that is the venous return, that is the venous return. And the person is changing the position from the standing to the supine. So what will happen, whatever blood pulling was there in the leg or the lower limb veins, that will come back to the heart, that will come back to the heart. That means in this particular question the venous return will increase, there will be increase in venous return. And if the venous return is increased, obviously the cardiac output will also increase, the cardiac output will also increase. They ask about the brain also. So what about the brain circulation or the cerebral circulation? Remember, the brain it is one of the best example for it have a best auto regulation. So that's why the cerebral blood supply will not change. So there is not much change. Temporarily it can vary for at some level, but not for the longer term. So the cerebral blood supply is always and always maintained. Always and always maintained towards the normal, Heart rate is usually normal. In the posture change, the heart rate is also usually normal. It is usually normal. So the only change in what thing? The only change in the venous return. And what happens if the patient is standing up from a lying supine? The reverse will occur. That means the venous return will decrease. And this reminds of one of the phenomena which is known as the orthostatic hypotension. Now, what is the orthostatic hypotension? Remember, there is a fall in the blood pressure. There is a very temporary fall in the blood pressure whenever you are standing up from the sitting or the lying supine position, right? So there is a fall or temporary fall, you can write, there is a temporary fall which is maintained by for few seconds, fall in BP. There is a fall in BP that happens when we change a posture from sitting or supine position towards the standing. There is a temporary fall in the BP which is usually maintained or regulated by baroreceptor, right? But if they fail to maintain, what will happen? The orthostatic hypotension will take place. The BP will remain low. That will cause a syncope or the fainting, right? So that is known as orthostatic. Whenever you are standing straight, the venous return will decrease suddenly. Why? Because that will go towards the lower limb, right? The blood will go towards the lower limb. So pulling off the blood will occur at this point of time whenever you are changing the posture from the sitting or supine towards the standing, and if the baroreceptor are failed to maintain this BP, the orthostatic, the hypotension will occur, that is a fall in BP. If it is not maintained, yes, the person may land up into fainting or the syncope, that is known as the orthostatic hypotension. Orthostatic hypotension. So, what is the first change? That is the venous return. So, answer of our question number 2110, that is the immediate increase in venous return. Immediate increase in venous return. So, that is about the question number 210. Answer is option C. Let's move on to the next question, that is 211. A lady lifts weight, right? So, which amongst this is not shortened? Basically, they are asking about the sarcomere, which is the anatomical and functional unit of the muscle. So, let's draw a sarcomere in the easier way. Let's understand how the sarcomere works. Suppose this is the actin filaments. These are the actin filaments and the thick myosin filament, and the myosin, they do have heads, right? They do have myosin heads. So, in the simpler form, this is the actin, this is the myosin. Myosin is always thicker, right? Actin and myosin. So, if we have actin and myosin, let's see what changes can occur. Actin and myosin. So, let's divide the actin band into half, where the myosin is not actually overlapping the actin. Not overlapping the actin, right? And which is known as which line? It is known as the Z line. This is known as the Z line. And where the only myosin fiber is there, that is known as the which zone? H zone. H zone. The whole myosin fiber overlapping the actin, that is known as A band. That is known as the A band, right? So, whenever the contraction will be there, what will happen? This myosin head, they will pull the actin fibers towards each other. They will pull the actin fibers toward each other. What will happen? Yes. Ultimately, the actin fibers will pull each other, get pulled towards each other. So, various changes will take place. Various changes will take place in the, basically in which band or fiber? The actin fiber. So, they will come towards each other. So, what changes will occur? Let's see first of all what is the bands and all. A band. What is the A band? Myosin and actin, or myosin overlapping the actin. You can write what is the A band? Myosin and the overlapping actin. Overlapping actin, right? What is a Z line? What is a Z line in the sarcomere? The Z line, the line which divide the I band exactly in the middle. Exactly in the middle, right? Remember, these Z line are not dividing or not doing the section from the actin in regards to actin band, so write down not in the middle of actin fiber, so not the actin fiber. So the actins, the overlapping myosin fibers, wherever the part of actin which is overlapped by the myosin, that will not be counted as in the I band, right. So that will not divide the actin fibers in the middle, but they will divide the I band in the middle, and which will not contain the part which is overlapped by the myosin, which is not, the I band is from here to here, which is not overlapped by the myosin. That means it is nothing but the only actin fiber, not overlapped by the myosin, right. And the Z line will divide this I band into two parts, right. So that is about the Z line I band. The functional unit, the whole unit is known as the sarcomere. And this is the unit of contraction. And what is the formula? Remember, formula is half of the I band over here, half of the I band, Z line, from one Z line to another Z line, that is nothing but the sarcomere. In between, the area between two Z lines. And what is that area? The half of the I band, this half I band, then the A band, and again the half of the I band. So formula, write down. What is the formula for the sarcomere? Half of the I band towards one side, then the A band, and again the another half of the I band. And what is the length? That will equal to around 2.5, 2.2 to 2.5, but if in the exam both options are there, go for the 2.5. And that is about the sarcomere, 2.5 micrometers. And we know what is the H zone. What is the H zone? H zone is nothing but only part of the myosin which is not at all, what thing? Not at all overlapped by the actin, So that is the H zone. Myosin not overlapped by actin. Myosin not overlapped by the actin, that is your H zone. So whenever the contraction will be there, what different phenomena or what different action in the various lines and the zones will occur? Remember, if this actin fibers will come close to each other, this H zone will be disappear. Similarly, the more and more actin will be overlapped by the myosin, so that's why the I band will be reduced too. So that's why what will happen? The I band will be reduced too, the Z lines will come closer. And that's how the sarcomere, the whole sarcomere will be shortened. So let's write down what will happen. First of all, the sarcomeres will come closer, the Z line that will come close, right. Then the H zone, ultimately this zone will disappear, that will disappear, right. What about another thing? What about the I band? The I band will reduce. The I band will be reduced. Why? Because more and more actin will be overlapped by the myosin, and I band is nothing but the only actin fiber, only actin which is not overlapped by the myosin. So I band will be reduced. What happened to the overall sarcomere? The sarcomere will be shortened. And what happens to the A band? Let's see what happens to the A band. Remember, the A band is myosin, whole of the myosin fiber. Either it is overlapped by the actin or not, it will not change, right? So whole of the myosin fiber, that will be remain same, right? So what will happen to the A band? No change. No change, that means the A band remains the same. Remains the same. Remains the same, so A band will not change. So let's see in the option. They ask which is not shortened. Remember, sarcomere will shorten, I band will shorten, the inter Z line distance. Remember, the Z lines will come closer, so distance will reduce. Only thing will not reduce, that is the A band, right? So answer of question number 211 is A band. Option C, A band. Okay, that is all about the question number 211. Let's move on to the question number 212. They gave in the diagram one particular pattern of the breathing, which is known as, which is known as question number 212. In the diagram, they give a particular pattern of breathing, which is known as crescendo decrescendo pattern of breathing. So write down, it is crescendo decrescendo pattern. In the diagram, whatever they gave, it is crescendo decrescendo pattern of breathing. It is a typical or the classical type of breathing pattern, which is a classical or the typical type of breathing, which is the kind stroke breathing, which is the kind strokes breathing, right? That is a crescendo or decrescendo patterns. In the this diagram, we have to see the upper, if we are going towards the apex, that is known as crescendo, and this is a decrescendo. So it is a diamond shape. Overall, if you see, it is a diamond shape. So it is also known as, the shape is diamond shape pattern, or the crescendo decrescendo pattern is seen, that is nothing but a classical kind stroke breathing. Classical kind stroke breathing, where it is appear if a person goes to the high altitude, this classical breathing will take place. Why? Whenever we are going towards the high altitude, the pressure of the oxygen in the environment will be increased. So atmospheric pressure, as it is increased, the gaseous pressure, what will happen? The person start to hyperventilate. Whenever we go to the high altitude, what will happen? The person start to hyperventilate. Now, if he start to hyperventilate, what will happen to the carbon dioxide? There will be carbon dioxide washout. There will be carbon dioxide washout. Remember, once the carbon dioxide washout will be there, what happens to the brain? The stimulus for the ventilation or for the breathing is the hypercapnia or hypoxia. If the carbon dioxide washout will be there, the stimulus for breathing will be lost, right? So for short duration of time, what will happen? The apnea will be there. The apnea will be there because carbon dioxide washout is there. Once the washout is there, ultimately the apnea will occur, and once the apnea for short time that is there, the carbon dioxide again will build up into the body, and what will happen to the oxygen level? They will reduce. So there will be a hypoxia, which in turns, this hypoxia, which in turns will stimulate the chemoreceptors. They will stimulate the chemoreceptors, and once the chemoreceptors are stimulated, again they will cause the hypoventilation. This particular cycle goes on and on and on. So the crescendo, what we are seeing over there, that is nothing but the particular pattern of, alternative hyperventilation and the apnea. at this particular phase the hyperventilation is occurring, and over here the apnea is taking place. Apnea is taking place. So what is happening over here? The hyperventilation is followed by the apnea. The hyperventilation is followed by the apnea, which is seen in the Kine-Stokes breathing, which is seen in the hyperventilation whenever a person goes to the high altitude. So it is nothing but the classical pattern of Kine-Stokes breathing. It is not a normal breathing, right? What about the Biot's breathing and the Kussmaul's breathing? The Biot's breathing, there is no particular pattern in the Biot's breathing is seen. So what happens in the Biot's breathing? In the Biot's, there is a irregular kind of respiration is there. There is a irregular respiration is there. That is nothing but a gasping type of respiration or gasping type of breathing. No particular pattern is seen. It is irregular. It is irregular, but only thing is it will occur with the spells of apnea. It will occur with the spells of apnea. So in the exam they give a statement, irregular respiration with the spells of apnea, you should go for the Biot's breathing. There is no particular pattern, but the spells of apnea is present in both, in the Kine-Stokes also and in the Biot's also. But in the Biot's there is no particular pattern, while in the Kine-Stokes there is a crescendo decrescendo pattern of breathing is seen, right? And where it can be seen, the Biot's breathing, as the Kine-Stokes breathing is seen whenever a person goes to high altitude, the Biot's breathing is majorly seen when in the patient of brainstem injury. It is seen in the patient of brainstem injury. It is seen in the patient of brainstem injury, right? What about the Kussmaul's breathing? So write down. You know the Kussmaul's breathing is mainly seen in the DKA, diabetic ketoacidosis. So Kussmaul's breathing. The Kussmaul breathing is the deep and labored kind of breathing which require efforts, right? More than normal efforts. So it is deep and labored breathing, mainly seen in diabetic ketoacidosis, which is in short DKA, known as in short DKA, but also in kidney failure. In the kidney failure. So that is all about the different types of breathing and where it can be seen, So answer of our question over here is option D, Kine-Stokes breathing, Kine-Stokes breathing. Next question, question number 213, the radius of the great vessel is increased by 2 times. What will happen to the velocity of the blood? So let's see what will happen to the velocity. What is the formula for velocity? What is the formula for velocity? Question number 213. Let's see. V, that is, what is the formula for velocity? Velocity is equal to the flow upon area. Velocity is equal to the flow upon area. Flow upon area. Right. What is the formula for area then? What is the formula for area? Everybody knows from +2 that the area is pi r square. Pi r square. And what is the r over here? The r is nothing but the radius. The r is nothing but the radius. But over here there is a power for this r. So if we increase the radius, what will happen to the area? So if we increase the radius, by 2 times, what will happen? 2 to the power 2, that means the area will increase by how many times? 4 times. The area will increase by the 4th time, right? So, if we increase the radius by 2 times, what will happen to the area? The area will be increased by 4 times. Area will be increased by 4th time, right? Because of the having the power to the radius. So, over here you can see that the area is actually inversely proportional to the velocity. So, if we increase the radius by how many times? By 2 times, there will be increase in area by 4 times, right? And since it is inversely proportional to the velocity, so the velocity will decrease by the 4 times, by 4 times, and this will go vice versa if we decrease the radius. So, by this simple 2 formulas, that is, velocity is equal to the flow rate upon area, and area is equal to pi r square, right? So, if we increase the radius, the area will increase and the velocity will decrease. So, answer of our question is yes, it is D. It will be decreased by the 4 times. Why? Because they ask about the velocity. So velocity will decrease by the 4 times. Let's move on to the next question. Oncotic pressure is contributed by. All the pressures are part of a Starling forces. So, if we have to discuss what is oncotic pressure, a pressure, the inward force which are created by the plasma proteins. So, write down about the oncotic pressure. What other things about the oncotic pressure we can discuss? Oncotic pressure. Oncotic pressure, it is exerted by plasma proteins. It is exerted by the plasma proteins, right? And usually how much it is? It is very small, that is usually it is 25 mm of Hg. Remember, this question is already asked, so get into mind that it is, remember this thing, that it is 25 mm of Hg, that it is 25 mm of Hg, the oncotic pressure, and which is exerted by the plasma protein. The osmolarity is because of the osmotic ions. If they ask about the oncotic pressure, you should go for this plasma protein. If they ask about the osmolarity, what is the funda about osmolarity? That it is because of different osmotic ions. For example, the sodium, potassium, chloride and all, right? And one sodium is how much? It counts for the 1 osmole. That is nothing but the 1000 milliosmole. How many questions asked on this? If you take 1 mole of NaCl, how many osmoles will be there? Remember, there is 1 mole of sodium and 1 mole of chloride. So, there will be 2 osmoles. That is 2000 milliosmole. So, that is for the example. What about the albumin? It is a type of plasma protein. But remember, it is a poor osmotic substance. I am talking about the osmosis, that it is poor osmotic substance. Why? Because of its bigger size. It have a big size than the other osmol like sodium, potassium, calcium, chloride and all. So albumin having a big size, that's why it have a poor osmotic substance. It is a poor osmotic substance. So it exert oncotic pressure of 25 mmHg as we saw, but since it is only present where in the plasma, right? It is not present in the interstitium. So what happens? But since it is only present in plasma, it create net inward force into the plasma, which is known as oncotic pressure, right? And since, what about the other things, that is the sodium, potassium, chloride and on, since, write down the ions like sodium, potassium, chloride, they are present in the equivalent composition or equimolar position, composition in the equal in both plasma and interstitium. Remember, I am talking about plasma and interstitium, not about the extracellular fluid and intracellular fluid, because they are different in the intracellular fluid and extracellular fluid, but plasma and interstitium, they have a equal concentration. So what will happen to the flow? So there is a no net flow. So no net flow, that means no net osmosis in between the plasma and the interstitium, especially by the sodium and all other ions. So the proteins are present inside the vessel, so they have a they become important part of the osmosis and which create the inward force. Why? Because they are present inside the vessel, only present inside the vessel, not in the interstitium, so they create the inward force towards the water, right? So that is known as the oncotic pressure. And what they do by creating the oncotic pressure, what they do, the plasma protein will maintain the volume. They maintain the volume of the plasma. So the oncotic pressure are basically, yes, whose function? That is a function of yes, the albumin, which is the type of plasma protein. So the answer of question number 214 is albumin, option D. Let's move on to the question number 215, that is the cerebral blood flow is increased by. Remember, we just now said that it is a brain is the one of the best example for the best auto regulation, and they ask about the cerebral blood flow. So the stimulus for this maintenance and regulation of the blood flow is also important. So first of all, write down the first segment statement, that is question number 215. Brain have a best auto regulation of blood flow. Brain have a best auto regulation of the blood flow, and who control which things maintain this balance? Write down, controlled by what thing we just discussed, that is it is hypoxia, hypercapnia. It is via hypoxia, that means decrease in partial pressure of oxygen, hypercapnia, that means increase in partial pressure of carbon dioxide, increase the partial pressure of carbon dioxide. And one more thing, that is increase in the metabolism by which cells? The brain cells, that is the neurons, the brain cells. Whenever there is a hypoxia, that means the partial pressure of oxygen will be decreased. Hypocapnia, that is the partial pressure of carbon dioxide will increase, and increase in the metabolism by the brain cells. What will happen? That will lead to increase in the yes, that will also lead to increase in the blood flow. Right. And one more thing, the potassium is continuously leaking. If the metabolism is there, what will happen to the potassium? The sodium potassium pump will be highly activated and the potassium will leak out. So the potassium, the metabolites are created via the metabolism. So the metabolites from the metabolism and the potassium ions, that is also one of the stimulus to have increase in the blood flow. And how this blood flow will be increased by this? Because all of this will cause, all of these four things, that will lead to a vasodilation in the brain. Cerebral vessels, that will cause a vasodilation in the cerebral vessel, and that will lead to increase in the blood flow, and the reverse thing will happen. Remember, if the blood flow will increase, what will happen? The more and more oxygen is coming towards the brain cells. So what will happen to the oxygen level? The partial pressure of oxygen will increase, and that will give a negative feedback response to the sensors, and through that, if the partial pressure of oxygen is increased, right, what will happen to the blood flow? The reverse will occur, the vasoconstriction will take place, and there will be a decrease in blood flow. So over here, for increase in the blood flow, what is required? In increase in the level of either increase in the level of carbon dioxide, metabolites, or the potassium ions, and decrease in the level of PO2, right. So all of the above cannot be the answer. Why? Because there should be hypoxia, that means a decrease in the partial pressure of the oxygen, not the increase, right. So A cannot be the option A cannot be the answer. Then option C is a decrease in metabolic rate. We just now discussed there should be increase in metabolic rate to increase the blood flow. So answer of this question is, answer of question number 215 is the increase in partial pressure of the carbon dioxide, increase in the pressure of carbon dioxide. Moving on to the question number 216, which type of sensory receptor labeled as X? So over here they gave X and Y. Remember, the X, which is present in the tendon, we already discussed, which is present in the tendon, which receptors? The tension receptors, that is the Golgi tendon organ, they are present in the tendon. This is the tendon of the muscle, and this is the body of the muscle, right, belly or the body of the muscle. In the belly or the body, muscle fibers are there which get lengthens or shortens. So to sense the length, which receptors should be present in the body? The Y receptors, that is nothing but the muscle spindle. So over here they shown the GTO, the X is GTO and the Y is muscle spindle. And what are the differences in those two? Both are the receptors. So in the question number 216, whichever shown by the Y was the muscle spindle, and the X is the Golgi tendon organ, remember we discussed that muscle have a two property, the length and the tension. the muscle spindle, let's discuss about the muscle spindle and the GTO. They sense, the muscle spindle sense the length, and the Golgi tendon organ, they sense the tension. Not only sense, they will regulate also. So muscle spindle will sense and regulate the length, and Golgi tendon organ will sense and regulate the tension. They will sense and regulate the tension. What next? Which were the sensory nerves through which it is carrying these sensations towards the alpha motor neuron? Remember, in the muscle spindle, 1A fibers were there and 2 as well as 2, while in the Golgi tendon organ it was 1B. Sensory afferents, you can write sensory afferents to maintain and regulate the sense and regulate the length, right? Sensory afferent, right? What they cause to the alpha motor neuron? Remember, the muscle spindle, they will stimulate the alpha motor neuron, while the Golgi tendon organ, they will inhibit the alpha motor neuron. They will inhibit the alpha motor neuron. Where they are present, the location, they are present parallel to muscle fibers. The muscle spindle, they are present parallel to the muscle fibers. We already saw in the diagram. What about the Golgi tendon organ? They are present in the series near the tendon. So parallel to the muscle fiber in the body of the muscle, body or the belly of the muscle, body or the belly of the muscle, right? And via stimulating the alpha motor neuron, what it will cause? It will give rise to the stretch reflex. What about the GTO? It causes inverse stretch reflex. Via inhibiting the alpha motor neuron, it is actually lengthening the muscle fiber, and that's why the relaxation of muscle will occur. So the muscle spindle will regulate the length, while the GTO, what they will do? They will prevent the rupture of the muscle. They will prevent the rupture of the muscle, right? That we already discussed in previous question regarding the muscle spindle and the GTO, muscle spindle and the GTO. So they ask the sensory receptor labeled as X. We already discussed the X is nothing but the Golgi tendon organ. Golgi tendon organ, right? So answer of question number 216 is option C, Golgi tendon organ. Let's move to the capacitance of the sperm occur in which of the following? Again the repro question. You must be knowing the answer of the question number 217. Let's discuss the question number 217 in the short. What is the capacitance actually? Remember, the sperms actually getting mature in the male genital tract, but it is getting incompletely mature. The further maturation, the complete maturation of the sperm, it will occur once it enters into the female genital tract. So the further maturation process, that is nothing but the capacitance which occurs in the female genital tract. So the capacitance is nothing but it is the further maturation of the sperm where in the female genital tract. And what is the major location? Once it enters into the uterus. Once it enters into the uterus. Once it enters into the uterus, it get further mature. So that is known as the capacitance. That is known as the capacitance. And why the maturation will occur over there? which things in the female genital tract will help them, help the sperm. The changes will occur for the maturation. The changes they occur mainly because of what thing? Mainly in uterus due to the pH. Main factor is the pH and the cholesterol. So write down mainly due to the pH changes, mainly due to the pH changes as well as and the cholesterol and the cholesterol. What they do, they help to fuse these two things. They actually helps the sperm, to fuse better with the ovum, to fuse better with the ovum, So the pH change and the cholesterol, right, and that is causing the complete maturation of the sperm which is occurring in the uterus. Where the sperms are actually produced, so let's write down physiological point of view some questions. The formation, sperms production, right, where they are produced, they are produced in the tubules. Which tubules? The seminiferous tubules, the seminiferous tubules, where they are stored, and storage as well as the gain, the motility, where both the function occur in epididymis. Remember, both the functions, the storage as well as the motility of the sperm, it is gained in the epididymis. The conduction of the sperm during the ejaculation, that occurs via the vas deferens. Right? The conduction will occur in the vas deferens. What about the maturation? They attain the maturation in both male and female genital tract. Incomplete maturation will be again also in epididymis, and the complete maturation that will occur in the uterus or female genital tract. So that is about the sperms, right? And what is the function of ejaculatory ducts? While the ejaculation, they will go through ejaculatory ducts. So production occurs in seminiferous tubules, the storage and motility, that as well as the incomplete maturation that occurs in the epididymis. Then the motility is also going in epididymis. The conduction will be through the vas deferens, nothing but the ejaculatory ducts, right? And the complete maturation ultimately will happen in the uterus, which is known as the capacitance, and that is occur mainly in the uterus. So they ask about the capacitance, so answer of our question will be D, uterus, right. What about the other questions? The neuronal cell type that is involved in the formation of a blood-brain barrier. Let's talk about the blood-brain barrier. How the blood-brain barrier is formed. The formation of the formation of blood-brain barrier. It is via which cell? It is by the astrocytes. Remember, it is via the astrocyte. So answer of this question is option B, astrocyte. Remember, microglia are nothing but the only supportive cells of the CNS system, and the Schwann cell, they causes the myelination in the peripheral nervous system, that is the PNS, while the oligodendrocyte, they will cause the myelination in the CNS, but the blood-brain barrier, it is formed by the astrocyte. Astrocyte, let's discuss some functions of the astrocyte. Quick functions of astrocyte. The different questions can be asked on the astrocyte. What are the different functions of the astrocyte? One that we just now discussed, that it make blood-brain barrier. What is this blood-brain barrier? It is a combination of the astrocyte as well as the tight junction. So it is a combination of astrocyte plus the tight junctions. Astrocyte and the tight junction. Occludin, Claudin, they form the tight junctions, but astrocyte is one of the major part of the blood-brain barrier, right? They also maintain what thing? They maintain the CSF composition. They helps to maintain the CSF composition. How? By metabolism. They cause the metabolism of different drugs, toxins and metabolites. So by metabolism and removal of different neurotransmitters, toxins and whichever drugs are entering, etc. So they cause two things. First is the metabolism of that particular thing, and then the removal from the CNS system. So that's how they maintain the CSF composition. What is the another function of this thing, the astrocyte? It maintain the ionic balance. It also maintain the ionic balance. It also maintain the ionic balance. Through what thing it will maintain the ionic balance? Mainly by the potassium. They cause potassium uptake. Remember, the astrocyte, they cause the potassium uptake, and via which they will maintain the ionic balance in the CNS. One more other function of this astrocyte is they also make or they form or they produce some of the neurotransmitter and the growth factor, for example the nerve growth factor. So they also make the neurotransmitters as well as growth factors, etc. They form the neurotransmitters as well as the growth factors. So what are the different functions of the astrocyte? Yes, we were discussing the question number 218, that first thing first, they will form the blood-brain barrier, right, with the help of tight junctions. The astrocyte will form the blood-brain barrier with the help of tight junction, which are made up of occludin, claudin and another cellular components, right. They maintain the CSF composition. How? Via the metabolism and removal of different neurotransmitters and the toxins, they will maintain the CSF composition. And what else? They maintain the ionic balance via which ion? The potassium uptake. They cause the potassium uptake, and through which they will maintain the ionic balance inside the central nervous system, especially inside the brain, right. And it also make the neurotransmitters and the growth factors. So answer of our question number 218 is the option B, astrocyte. The microglia, they are the supporting cells. The microglia, they are the what thing? They are the supporting cells of the CNS, right. the Schwann cells and the oligodendrocyte, they will form the myelin sheath. The Schwann cell in the CNS, they will the PNS, that is peripheral nervous system, they will form the myelin sheath. The oligodendrocyte in the CNS, they will form the myelin sheath. They will form a myelin sheath. So that is all about the physiology part of GT 185. That is all about the physiology part in the GT 185.